Hello guys, welcome to our channel. Today we are going to discuss the part 2 of the pediatrics. In this we are going to discuss the respiratory system and also the cardiology, neurology and other important miscellaneous topics we are going to discuss guys. So before we start the session, I want you guys, those who are new to this channel, please do subscribe and share with your friends, and soon we are going to start the rapid revisions and also short series image based discussions in the upcoming June 30th examination. We are going to complete all the 19 subjects, smart rapid revision programs, and also short series and IBDs. So stay tuned and subscribe and share with your friends. So let's start the today's session, part 2 of the pediatrics. So let's start with the pulmonology. So first and most important topic is the IMNSC. Okay, these IMNSC is the management, that is protocol which is used around the PHCs in the India. Okay, so we are going to follow the three color codes. Okay, green, yellow, and the pink. So green is always, that is a very less risk or the no risk at all. Yellow is the mild risk, and pink is considered as a very severe risk for the patient. So what are the symptoms? In the no pneumonia, the patient will be suffering from the common cold, fever, and just mild symptoms. So we can just give the supportive treatment at the home only, paracetamol, and symptomatic management is fine for the patient. Pneumonia, the patient will be having the same symptoms, but there will be fast breathing or chest indrawing, but SpO2 is normal. Okay, so the fast breathing or the chest indrawing with SpO2 normal, then the patient is suffering from the pneumonia. What is the treatment? We have to prescribe the oral antibiotics for the 5 days, and we have to evaluate that for the baby, is there any TB if the cough is more than 2 weeks. And if it's a severe pneumonia, the patient SpO2 will be falling, and there will be presence of the one or more danger signs will be seen, like lethargy, not feeding, convulsion, cyanosis, any of one, the danger sign will be seen. Okay, so how can you easily recognize? If there is a common symptoms but no respiratory distress, it is a no pneumonia. If there is a fast breathing or the chest indrawing but SpO2 is normal, then it is a pneumonia. If it is a severe pneumonia, there will be must and should there will be a danger sign. So you have to urgent referral and give one dose of IV antibiotic immediately at that clinic itself. Okay, PHC or the subcenter you have to give. This is the IMNCI guidelines for the pneumonia. Next, bronchiolitis. What is the most common cause for the bronchiolitis? It is the respiratory syncytial virus, commonly seen in the less than 2 years of the age people. Okay, and what is the pathogenesis? Generally, it is going to bronchiolitis. That means the bronchioles is going to get inflamed, and edematous and the mucus production and the airway obstruction is commonly seen in this patient. So, kind of here you can see this is air hyperinflation. Okay, air hyperinflation, because air is trapped inside the lungs which cannot go out because of the edema is filled in the bronchioles. It is a self-limiting condition, but in rare cases we have to give the ribavirin and O2 inhalation and the fluids in the severe condition, but most of the cases will be mild and moderate only, and very symptomatic supportive treatment is fine. And pavlizumab, this is the anticlonal mono anticlonal antibody, and this is given for the mostly immunocompromised patients. Okay, those who are suffering from the severe immunocompromise, we can give as a prophylaxis for that patient. Next, coming to the cardiology, acute rheumatic fever. In the acute rheumatic fever, you have to understand the important criteria is Jones criteria. What are the major and what are the minor? Based on this, we are going to diagnose the condition. For the major conditions such as pancreatitis, polyarthritis, syndrome chorea, and subcutaneous nodule and erythema marginata. Okay, there are 5 major criteria. Minor criteria such as fever, arthralgia, differency, it is arthritis, it is arthralgia. Prolonged PR interval on the ECG finding. There will be increased ESR CRP levels and also leukocytosis. Okay, so this is the minor criteria, and we have to follow the high risk population only, because India is at prone of the high risk population. And along with that, you also have to have the essential criteria which show that the streptococcal infection is positive previously, such as ASO titer or the throat swab culture that should be presented as an essential criteria. And how can you diagnose case? First episode, if it is presented, two major criteria or one major, two minor criteria. If it is a recurrent, again two major or one major, two minor or the three minor criteria is considered as for the diagnosis of the acute rheumatic fever. And what is the main cause of the acute rheumatic fever, guys? The main cause is the streptococcus, right? Streptococcus infection. After 2 weeks of the infection, it is going to cause the molecular mimicry. It is going to cause the molecular mimicry, and these molecular mimicry that is going to cause this condition in this patient. Most commonly these patients will be suffered from the heart disease only, and mostly mitral stenosis and followed by the mitral regurgitation, which is the most common presentation of this patient that we are going to see. And next, coming to the congenital heart disease. One is the cyanotic and other one is the acyanotic conditions. What is the most common, guys? Overall, the most common cause will be the acyanotic, okay, followed by the cyanotic conditions, okay. And in the cyanotic, here let's we discuss that is the tetralogy of Fallot. In the tetralogy of Fallot, what are the four important criteria that you should know? The main cause of the tetralogy of the Fallot will be the subpulmonary stenosis. Okay, that is the main cause. Along with that, there will be overriding of the aorta, right ventricular hypertrophy, and ventricular systole, ventricular systematic. That is, there will be VST also. Shunt will be also seen in the ventricles. Okay, so these four defects that is going to comprise the tetralogy of Fallot. Due to subpulmonary stenosis, the patient will be having the blood that will be coming from the oxygenated to the deoxygenated side, and it will cause the deoxygenated to the oxygen side, that will cause the mixing of this blood, and the patient will be suffering from the cyanosis. Okay, this is the one of the major things that you have to note in the TOF. And what is the murmur? That is the ejection systolic murmur, and cyanotic spells will be seen on the X-ray. You are going to see the boot shaped, this boot-shaped heart will be seen in this patient. And shunt surgery, the name of the shunt surgery is fine. The name of the shunt surgery is the classic bulkoctotic. That is the classic bulkoctotic surgery can be done for this patient. Next, tricuspid atresia. In the tricuspid atresia, the patent foramen ovale, and that is the present in this patient, and there will be overload of the blood in the left atrium, and left ventricle leads to the hypertrophy of the left heart, and that is going to see. And same surgeries like a BT shunt or the Glenn shunt or the Fonton shunt that can be done for this patient. Ebstein's anomaly, and in the Ebstein's anomaly, this is due to tricuspid regurgitation. What happens most commonly? There will be the right ventricle is going to be atrialization. Okay, the right ventricle is going to convert as a atrialization, and this atrialization is going to be seen in this patient, which is associated with the lithium exposure. Okay, remember, there will be lithium exposure that will be seen in this patient, and box shaped heart is the X-ray finding that we are going to see. Next, transposition of the great arteries. The transposition of the great arteries is the due to intact ventricular septum in the embryogenesis. What happens? It has to be the left ventricle has to shunt into the aorta, right? And the right ventricle has to shunt into the pulmonary artery. What happens in the transposition? The left ventricle is shunt into the pulmonary artery, and the right ventricle shunting into the aorta. So these going to cause the transposition. And on the X-ray, you are going to see this kind of egg-shaped heart that you will be seen. Egg on the string appearances will be seen in this patient. Next, cyanotic heart diseases. In the most common cyanotic heart diseases will be the VST. Okay, the VST is the most common overall, and atrial septal defect is the second most common. But in the atrial septal defect, the most common will be the ostium secundum defect, and second most common is the ostium primum defect. And the murmur that you have to remember, there will be delayed ejection, delayed diastolic and ejection systolic murmur with the wide fixed S2 splitting will be seen in this patient. Next, ventricular septum. The most common cause is this is overall acyanotic, and in that the most common form is the perimembranous type of the ventricular septal defect. The murmur will be pansystolic murmur. Complications: the patient will be having a lung congestion, congestive heart failure, infective endocarditis, and Essen-Menger syndrome will be also seen. Patent ductus arteriosus, this is associated with the congenital rubella, and the blood flow from the aorta to the pulmonary artery via patent ductus arteriosus. And the murmur will be continuous missionary murmur will be seen, and management is the indomethacin. Basically, we are going to use the ibuprofen in the India. Indomethacin is commonly used in the USA, but if you want to prefer the answer, our answer will be ibuprofen. Okay. Ibuprofen is generally used for the better renal profile in the India. Next, gastroenterology. The first and most important, breastfeeding. The absolute contraindications is the lactose intolerance, galactosemia, chemo, and the radiotherapy. The relative is the HIV. HIV is commonly given with the prophylaxis. You will be learning in the PSM. And mixed feeding is contraindicated. Mothers, those who are on the antiretroviral therapy, and nevirapine prophylaxis for the neonate. And especially if the mother is untreated less than 2 weeks, we are not going to give for the TB patients also. Active herpes lesions at the breast region also, we are not going to ask for the weaning. Feeding in the preterm babies. If the baby is less than 28 weeks, there is a motility that is really decreased. So we are going to give the total parenteral nutrition only. If the 28 to 31 weeks, mostly via nasogastric or the orogastric tube, and 32 to 34 weeks, then we are going to give via katori spoon, paladai spoon, which we are going to use. More than 34 weeks, there will be sucking reflex. The baby will be having the sucking reflex and the rooting reflex, both are present. Then we can directly go for the breastfeeding in these patients. Next, ORS formulation and the resomol formulation. I prefer ORS formulation more important than the resomol. As per the osmolality of the ORS, which is equal to the 245, and sodium 75, glucose 75, potassium 20, and chloride 65. This is absolutely an important question for your examination. How the ORS is going to act via SGLT2, it is going to act in the body. Okay, SGLT2 and also SGLT1. The most important is the SGLT1 in the intestine. Okay, one for one and one for intestine, that you have to remember for the reabsorption. And resmolol, which is we are going to use for the patients those who are suffering from the malnutrition, and for them you have to remember just like important points, the glucose 125, sodium 45, potassium 40, and the chloride 70, and total osmolarity will be the 300. Next, diarrhea IMNCI guidelines. First, you have to divide the patient whether it is no dehydration, some dehydration, or the severe dehydration. First and most important is the neurological condition. If the patient is active and alert, there is no signs of the dehydration, irritable, some dehydration, lethargic, the severe dehydration, and other signs such as the normal eyes, normal tears, normal mouth, and normal thrust, and the skin pinch also less than 1 second. Absolutely, there will be no dehydration in this patient. Some dehydration, the patient is irritable, sunken eyeballs, tears is absent, dry mouth, and severe thirst, and very slow skin pinch test. Some or the moderate dehydration is present. And severe dehydration associated with the lethargy, very sunken eyeballs, absent tears, very dry tongue, unable to drink, and the patient is very slow to recoil, skin recoil, or the skin pinch test that will be seen in the severe condition. So how we are going to give this condition? So no dehydration, you just have to give the ORS replacement for 1 episode. For every 1 episode, you have to give the ORS packet as the possible for the patient. Some dehydration. In the some dehydration patient, how we are going to proceed? For the patients, those who are getting from the some dehydration, we are going to tell them to bring to the first to our place. And how we are going to proceed here? We are going to give the patient rehydration solution as per the weight. Okay, 75 ml per kg ORS over the 4 hours we have to give for this patient. Because the patient is irritable, there is a high chance he can go into the lethargic condition also. And replacement for the ongoing losses. For one episode, 1 ORS, again you are going to give, and extra 75 ml per kg also you are going to give. And along with that, there will be daily fluid replacement using the holiday cigar method. Also, we have to give for this patient. Then the severe dehydration. Here we are going to attach the IV fluids for this patient. In the IV fluids, generally we prefer the RL and also the 5% of the dextrose that should be given for this patient, and 30 ml per kg, that is for the less than 1 year, and 70 ml per kg again less than 1 year for the 5 hours. This is how we are going to calculate, and this is not so important for the part of the calculation, but at least you have to know how the management should be done for these patients. Next, in neurology topics that we are going to discuss, the seizures. Seizures is very commonly present in the children, and later on the life other people will be alcoholics. Mostly these people are most prone for the seizures. And febrile seizures is the most common overall. The most common overall is the febrile seizures. And this is associated with the fever. The name itself telling it is a febrile seizures. The treatment for the fever, symptomatic paracetamol should be given. For the seizures, you can give the immediate IV lorazepam should be given for this patient. Absent seizures seen in the more than 5 to 12 years children. This is going to last for the 30 seconds, and on the EEG you are going to see the 3 heads of the spike wave pattern, and the drug of the choice is the valproate. That is the important one. Juvenile myoclonic epilepsy, Zan's syndrome. The drug of the choice is the valproate. EEG findings is the 4 to 6 heads of the polyspikes and the wave pattern, and this is seen in the adolescence where there will be sudden contraction of the muscles with the involuntary jerky movements. Next, West syndrome. This is associated with the less than 1 year children, developmental regression, high voltage spikes on the EEG, and the drug of the choice will be the injection ACTH. But if the West syndrome is associated with the tuberous sclerosis, then my drug of the choice will be vigabatrin. Dravet syndrome, drug of the choice is the valproate. Lennox-Gastaut syndrome, and this is also the drug of the choice is the valproate. Next, cerebral palsy. In the cerebral palsy, the most common chronic motor disability that is associated with the children. And in this patient, there will be static encephalopathy. That means there will be non-progressive damage to the developing brain and irreversible due to trauma in the perinatal period infections, or the postnatal period. There will be, if there is a trauma, infection, or any multiple cause that can cause this cerebral palsy. There will be types. One is the diplegia, hemiplegia, and the quadriplegia. The diplegia both lower limbs, hemiplegia only one side, quadriplegia all the 4 limbs. So this is the most common form in the India and most common type of the cerebral palsy. Mostly associated in the preterms, neonates, and the birth asphyxia in the term babies. Sequelae will be periventricular leukomalacia, neonatal stroke, and parasagittal infarction will be seen in these patients. Again, the clinical features will be spasticity, seizuring posture, toe walking, cortical thumb, and vision abnormalities, hearing abnormalities will be seen. Mostly symptomatic treatments such as baclofen, botulinum toxin, and also trihexyphenidyl and the levodopa. As per the symptoms we are going to give for these patients. CNS infections. The most important CNS infection is the meningitis, right? In the meningitis, if it is a less than 2 years, most common is the GBS. This is worldwide. And equally the most common in the India. 2 months to 3 years, Streptococcus. 3 years to 12 years, Streptococcus. More than 12 years, Streptococcus. Overall will be the Streptococcus pneumonia only. And important part is the CSF analysis. At least one question every year. So normally we are going to see very pale. It just look like a crystalline water only. and there will be less than 5 mm of the lymphocytes. That will be very less, minimal, and protein is just 20%. Glucose is 50%, because coming to our glucose, if it is 100, half, there will be 50. Okay, in the CSF only half of the glucose will be seen, and clear crystalline sterile free fluid will be seen in the normally. And in the bacterial, you are going to see this kind of yellow color. There will be increased neutrophils, okay, increased protein, and decreased glucose. If it is a 50 already, it is going to even decrease to 20. And next, viral. The viral will be resemble the mostly normal itself. There is a slight confusion, but there will be presence of the lymphocytes. The normal pressure, normal color, normal cells, normal protein, everything will be normal, but there will be presence of the lymphocytes. Whereas tuberculosis, it is associated with the severe proteinuria, and severe lymphocytes will be seen. Okay, that is the difference between the types of the CSF analysis. And there will be Brudzinski sign. Here you can see the Brudzinski sign on the neck flexion. There will be legs that will be associated with the Brudzinski sign. And Kernick sign, when you are lifted the patient knee, there will be voluntary. If there is a pain in the near the nuchal, there will be patient involuntary sign will be associated with this in this patients. This is the Brudzinski sign. This is the Kernick sign. This is also asked as a image based question. And genetic conditions. Down syndrome. This is due to trisomy 21. Which is most common cause? The maternal age associated with the meiotic non-disjunction of the chromosome 21. What is the features of this baby? Mongoloid slant. Here you can see this is the mongoloid slant. Epicanthal extra folds, flat nose, flat face, flat occiput. Here you can see flat face, flat occiput, low set ears. The ears at least present here, but the baby ear is low set, protruding tongue, and single transverse crease. Here there will be single transverse crease and increased gap between the 1 to 2 toes. And associated problems: endocardial cushion defect, mental retardation, hypothyroidism, and Alzheimer's disease. Most common leukemia overall, ALL. If it is less than 3 years, then AML M7. Klinefelter syndrome due to extra X chromosome, tall stature, long limbs, testicular atrophy, gynecomastia, delayed hair growth, cryptorchidism, and low IQ. Turner syndrome. This is due to absence of the X chromosome, short stature, webbed neck, and normal intelligence. And heart defect is a bicuspid aortic valve and coarctation of aorta. These are the features. And streak ovaries, delayed puberty, that is associated. Infertility is also seen. And most commonly renal abnormalities such as horseshoe kidney will be seen. Edward syndrome. E for Edward, E for 18. This is the second most common of the trisomy. And what are the features that you have to remember? Rocker bottom feet. This is the rocker bottom feet. And there will be occiput back foot as the skull is very prominent. That's why it is sometimes is also known as a strawberry head. Clenched hands overlapping of the fingers. Here you can see the hand is clenched with the overlapping of the fingers. Next, Patau syndrome. This is 13. Microphthalmis. Here you can see this is the microphthalmis and undescended testis, and also aplasia cutis and clenched hands, dysplasia, cleft lip. These are the association. Patau syndrome. Miscellaneous topics such as sickle cell anemia. This is an autosomal recessive condition. This is due to glutamate, which is replaced by the valine at the sixth position. And clinical features such as it is going to associated with the sickling of the cells. Here you can see these are the sickle cells due to low oxygen, and which is going to cause the features like the fever, breathing difficulty, autosplenomegaly, recurrent infections, hand foot syndrome, dactylitis, icterus and pallor that will be seen associated with the sickle cell anemia. And what is the test? Sickling test. If you add the 2% of the sodium in the blood sample, you are going to see this kind of the sickling of the cells. The best test is the high performance liquid chromatography. This is the gold standard therapy. The drug of the choice is the hydroxyurea. Wilms tumor. This is most common solid tumor of the kidney and second most common of the intra-abdominal tumor of the neuroblastoma. Origin is the neurogenic rest. Risk factor: Weger syndrome, Danny-Drash syndrome, Beckwith-Weidman syndrome. These are the three important syndromes that is associated with the Wilms tumor. Remaining are not so important, and features will be mostly asymptomatic and unilateral abdominal mass, like sporadically or the incidental finding only the patient will be presented. The metastasis is most common to lungs. Radical nephrectomy is basically we are going to proceed for the mostly radical nephrectomy only. Juvenile idiopathic arthritis. This is most commonly arthritis that is seen in the children at least 6 weeks in the less than 16 years of the old age people. And it can be different types. One is the oligoric, other one is a polyarticular and systemic onset. Oligoarticular means only less than 4, polyarticular more than 5 joints, and systemic will be associated with the fever. Okay, this is the types of the juvenile idiopathic arthritis. And the treatment of the choice for this patient is the steroids. Next, Kawasaki disease. It's a heart condition where you are going to see most commonly seen in the mid size of the vasculitis. Types will be acute phase, subacute phase, and the recovery phase. These both are severe because in the subacute phase, the patient will be having a myocardial ischemia, coronary artery aneurysms, and coronary vessel thrombosis. Acute phase, the baby will be having the fever more than 5 days. Along with that, there will be other features such here you can see conjunctivitis, enlarged lymphadenopathies, fever, and also there will be strawberry tongue and rash. Okay, edema is also seen. These are the other features. Okay, and criteria is also same, like there will be at least one fever plus more than one symptom, any four that can be present in this patient. Treatment will be IVIG. Aspirin can be given accordingly during the fever high dose. During the antiplatelet low dose should be given. Next, Hennon's clinic purpura. This is the most common small vessel vasculitis, IgA mediated, and there will be non-thrombocytic palpable purpura in the lower limbs and
These are the
abdominal pain
important
and
points and the
arthralgia
diseases that you
arthritis
have to remember in this
and
condition.
normal
Those who are new to this channel, please do
thrombocytopenia. That
subscribe.
is the most differences. Okay, normal thrombocytopenia that is seen. Treatment is steroids. Cystic fibrosis, this is an autosomal recessive. The chromosome 7 CFTR gene is involved. Most commonly it is involved the respiratory, recurrent pneumonia, bronchiectasis, bilateral nasal polyps. In the neonates, meconium ileus, and in the adults there will be malabsorption, pancreatic insufficiency. Reproductively, the patients will be having the infertility. Why infertility? Is due to congenital absence of the vas deferens, but the sperm is normal. Laboratory, 2 elevated sweat chloride tests, that is more than 60. 2 samples that should be positive. Treatment is ivacaftor, lumacaftor, that is a CFTR modulator. Remember, cafters are the treatment of the choice. Congenital adrenal hyperplasia, most common adrenal disorder in the children. How can you identify? There are the types of the enzyme defects such as 21, 11 beta, 17 alpha. Most common overall is a 21. So remember this way, whichever the number 1, for example 21, 17. So the one number will be elevated. Okay, one number will be elevated, and 2 number or the other number will be decreased. So BP and androgens, 21 hydroxylase patient BP will be low but the androgens are high. 11 beta BPV high, androgens high. 17 beta BP high but the androgens are low. That's how you can remember. Next, celiac disease. This is due to gluten hypersensitivity associated with the HLA-DQ to HLA-DQ8. What are the gluten foods? Barley, rye, oats, wheats. These are absolutely going to cause the celiac disease, gluten insensitivity. The patients are associated with the malabsorption, iron refractory anemia, and when you test them, there will be most commonly positive for the anti-TTG IgA positive will be seen. And most specific is the anti-endomysial antibody. Gold standard is the biopsy. On the biopsy, you are going to see the crypt hyperplasia, villus atrophy, increased intraepithelial lymphocytes. What is the treatment? Please go for the gluten-free diet. No need to take any of the gluten, just avoid them. That is the treatment. And complication associated with the dermatitis herpetiformis, where is the autoimmune blistering skin disease also associated. Congenital hypothyroidism, there is the most common cause is the thyroid dysgenesis. Second most common is the dyshormonogenesis. First, the gland that is absent, and second, that the hormone is absent. Lethargy, hoarse cry, hypothermia, dry skin, wide open fontanelles, umbilical hernia, macroglossia, delayed passage of the meconium. These are the features of the congenital hypothyroidism. Investigations such as the serum TSH should be done in the by birth itself, immediately after the birth, and neck ultrasound if there is a swelling, and radionucleotide scan can be done, and less likely this is done, but most commonly serum TSH and the neck ultrasound is done. So these are the important topics of the pediatrics part 2, and remaining any important topics like GI, that is going to be discussed in the surgery, and some of the respiratory, whichever requires the more elaborative approach from the surgery, we are going to discuss in the surgery topic. Okay, these are the some of the important topics. Please to subscribe and stay tuned. We are going to have the rapid revision program, short series, and the image based discussions. Until then, see you guys and thank you.